Hello everyone, my name is Joe. I'm an anaesthetic trainee in the northwest of England. Thank you to the committee for allowing me to present this work that I have done over the past year at this conference. I'm very grateful and thank you for inviting me. This is an audit that I did with one of the consultants at another intensive care unit in the northwest of England, the Salford Royal NHS Foundation Trust ICU, and that's Dr. Anthony Thomas. The main background to this audit is identifying the patients with delirium. And it's important to identify the patients with delirium because we need to prevent delirium, treat it, and see how well we can manage delirium. Delirium is a very common presentation in ICU, and many patients unfortunately suffer from delirium. So getting better at managing delirium is something that will inevitably improve patient outcome. And what we really need is to recognize delirium. And one of the methods that is used to recognize delirium is the CAM-ICU method that I will go through later. So what we did was to look at the delirium assessments and the outcome of patients through a whole year after admission in the ICU. We wanted to look at the compliance with the delirium assessments. We wanted to look at how often these patients were meeting the different components of CAM-ICU, which I'll go through later, and check what the survival rate of these patients were. Now, this is a very critical care orientated audit, but delirium is something that many patients suffer from throughout the hospital. So I think there are learning elements from this that can be used in all aspects of healthcare. The standard that we set was to have twice daily CAM-ICU assessments, which meant that we could recognize patients with delirium as it's an intermittent presentation. And we were looking at the electronic records for patients that we used at Salford Royal Hospital. Now, having the access to these records through EPR allowed us to audit the compliance to our standards. We also were able to look at the outcomes of patients with the different types of delirium and the different components that they met through the CAM-ICU methodology, and review at what frequency they met these different elements. So, like I said, the CAM-ICU is one method that has been used for ICU patients. And the main idea is working through this worksheet or this ordered questionnaire that allows us to recognize the patients that are delirious, so they were CAM-ICU positive, or they had other errors such as inattention errors, altered level of consciousness, or disorganized thinking, but they were not CAM positive, i.e. they were CAM negative. Therefore, there was something that was not quite right in their cognitive processing, but they were not confused. The Salford Intensive Care Unit had 32 beds that included general ICU and a neurosciences critical care unit as well. We looked at the records for patients from August 2018 to August 2019. And like we said, I looked at the patients that were delirium positive, both with and without agitation, and also those that were negative with and without cognitive impairment. And that was divided into those that had inattention errors or disorganized thinking. These Excel sheets were then used to link to the patients that were found using the ICNARC database. So this is the National Audit and Research Centre. So every patient that's been admitted to the UK Intensive Care Unit will end up on this database and will have several data points, including the reason for admission, their comorbidities, social history, the length of stay, and their outcome as well. So this meant it was quite easy to look at the patients with different elements of delirium, positive and negative, and look at the outcome of these patients. Throughout that year, there were 6 occasions. So every couple of months, the nursing staff were given an update on what the rate of compliance were for the CAM ICU assessments looking through EPR. This would happen during a daily huddle in the morning or in the evening, so that as many staff members could be involved in this update. So what did we find? We found that there were 2,700 admissions. That was a total of 2,400 total patients, which meant there were readmissions, and just over half of them were male. The average age of the patients were 57, and these are the data points that were collected through the ICNARC records. CAM ICU patients or CAM ICU assessments, like we said, were to be done twice a day. So there were 10,500 assessments throughout that whole year. And that involved 1,358 patients. So there were a several number of patients that did not have any CAM ICU assessments. This could be due to several reasons, including a very short stay where they had unfortunately passed away, or they may have been admitted to the neurosciences unit where it's not common for them to perform the CAM ICU assessments compared to the general ICU where that's a regular practice. So that's an 8-bedded unit where that might not have occurred on a regular basis. So out of all the 1,300 patients, there were 1,191 who had full ICNARC records. So again, that could be because the patient data wasn't collected during the periods of August 2018 to August 2019. Therefore, they might have missed the ICNARC database when they were being exported. What I did was look at 6 patients that did have delirium, and I filled out the relevant ICNARC data looking through the electronic records because it was important to look at the outcome of these patients. So out of those 1,191 patients, 167 of them had remained in coma. Therefore, the CAM ICU assessment was not applicable. 214 patients, that's 18%, or just under 1 in 5, had at least one positive assessment. So during their stay, at least 1 in 5 patients were positive for CAM ICU. The rest of the 977 patients, there were 82 patients who had cognitive impairment, whereas the rest of them didn't. Now, looking at the assessments on their own, most of them, unfortunately, they were not deeply sedated. So that means they were eligible for having the CAM ICU assessment. 989 of the assessments did have an acute change from the baseline mental state, and 775 had more than 2 inattention errors on the assessment. 246 were calm, and 199 had more than 2 points for disorganized thinking. Now, the main point of this slide to take away is the fact that just under 1 in 5 patients who are admitted to critical care at one point will be confused. And that can be for a whole variety of reasons, which I will again go through later. This was a flowchart to look at the different 2 different databases that were used and the 2 different assessments that patients would have had for being delirium or not having delirium assessments done. This was to look at another flow chart looking at all the patients that had delirium assessments and had full ICNARC records, and This looks at the division of the patients that were excluded and the patients that did have delirium, and what those that had a negative CAM ICU assessment but did have cognitive impairment with the duplicates removed. Again, it's just a flow chart to look at the flow of the diagram and the flow of patients. This is yet another figure that shows the flow chart of patients that had the inattention errors and those that had disorganized thinking. And it is important to look at this because often the CAM ICU methodology recognizes those that are confused. However, it is very common to ignore those that may have some inattention errors or disorganized thinking, but this unfortunately does affect the outcome of patients, and it's been shown that they do have a higher mortality compared to those who have no issues during their stay and have normal thinking throughout. So like I said, 1 in 5, or just slightly less than 1 in 5, suffer delirium while they're in ICU. Now, those that do have delirium, they're more likely to be male. They more than likely have a longer length of stay in hospital, and they have a longer stay in ICU compared to those without delirium, which is understandable. Those that have a CAM ICU positive are in ICU for roughly around 9 days, whereas those that have no elements of CAM ICU stay for 3 days, and those with some sort of cognitive impairment stay somewhere in the middle, around 4 days. Sorry. The patients with delirium did need more organ support, and they unfortunately had a higher mortality at discharge, and that's 14% compared to 9% of the patients that had no delirium during their stay. And the overall mortality from hospital is also increased from 30 days and to 1 year, from 13 to 22%. It was also recognized that those that died were older and they had more comorbidities and they had worse functional status than those that survived. So this is a confounding variable that may have also affected the mortality rate of these patients, but it can also be suggested that these are the patients that are more likely to suffer from delirium. In terms of compliance, only 23% had an assessment completed once per shift, i.e. twice a day, and 62 had once per day. And in patients that had a positive assessment, 65% of the cases had investigations to identify a cause, and 42% required some form of restraint, and 65% of these patients had cognitive impairment at discharge from ICU. So again, we can see this is a huge burden for not just critical care unit, but also ward, and ultimately once they reach home, for families and carers once these patients are discharged, because it can be something that will last weeks to months. Now, those suffering from hypoactive delirium, we noticed, were older and they were more likely to die, and their 1 year mortality was 26% compared to 22%. This is a quick slide just to look at the division of what the hyperactive and hypoactive delirium shows, and also patients that were alive versus dead at the end of their hospital stay, to look at what changes and what number of assessments were done. Now, the limitations to this audit and data collection were there were lots of databases with no link between them. It's quite time consuming to look through thousands of patients and look at the full admission notes during a whole year. And this was done by one person, which makes it even more difficult. There's no effective single search function on our electronic records, unfortunately. So this is something that I've raised and hopefully can be sorted out. Now, looking at the actual compliance, unfortunately, we've got into this habit of having lots of paperwork for nursing staff. How can we make this better? again, I think it's something that needs working on from all angles, from nursing side, from the medical side, and trying to streamline a process that makes it easier for nursing staff with the amount of paperwork that they have to do so they can actually care for patients. The other thing I noted was, is it possible to take delirium data sets from other assessments? So this is where our medical colleagues can come in. There's twice daily reviews from the medical staff for all patients. So adding in a CAM assessment into these reviews is not very time consuming, since you have to speak to the patients and assess them. So this might be taking some workload off the patients, off the nursing staff, sorry, and which meant our compliance would be even higher. But also it would mean yet another person that is there to recognize a patient that might be delirious and have a speedier management and recognition for these patients. The other thing that most of these, the compliance we don't take into account is how busy the unit and the staffing levels might be. If there's less staff and if it's busier, often these things, such as paperwork for CAM assessments, might fall to the bottom of our lists, which is completely understandable. And again, it's an educational opportunity for our new doctors during their induction, so that it's not a pure responsibility for the nursing staff. So through this study, what we wanted to conclude was that even with feedback just to purely nurses, it was difficult to get daily assessments and twice daily assessments for these patients. They often might have been assessed for CAM ICU and noted to be confused, but there's not documentation, which is unfortunately how we assess the audit standards for such things. Looking at medical staff to complete these CAM ICU assessments might help compliance, but also it allows speedier recognition. And unfortunately, it's something that we knew before, but it's a further evidence to suggest that the patients with delirium are more likely to be male and they do have a higher mortality. And this lasts not just from our ICU stay, but it lasts through the rest of their hospital stay and often a year after the discharge from the unit. And it does have a huge burden for several members. So what can we do to get ourselves better? This is something one of our consultants, Dr. Tony Thomas, started in our ICU, but it's not something that just needs to be in the ICU and can be added to everywhere. And it's something that we should all really do. So I've tried to practice this as best as I can. And it's speaking to our patients and giving them a reorientation process so that they know exactly why they're in hospital and what the day, the date, and the time is and where they are. Obviously, this is not something that we have to do for all our patients because not all our patients will be confused and delirious. For those that are delirious, they can be a quick start. And those that are awake, we can have a conversation to see if they're delirious, if they're confused, or if they're orientated. Specifically to critical care, those that are asleep or those that might seem asleep and unconscious, I think it's still important to speak to them such as this and introduce yourself and explain what you're doing, because from follow-up clinics, we know that these patients do remember certain snippets. And even if they don't mention that they do remember, they might still have those memories, even if they're little short snippets in their head. And it's important that we do keep talking to them because it's part of our assessment. And these are the things that I mentioned would be the causes of delirium and need further investigations. So pinches me is a mnemonic that we used in the northwest of England, and it allows a quick assessment of different things that we can help to mediate and investigate to allow our patients to be as comfortable as they can. And obviously medication refers to medications that they are started on, not medications that we can give them, because the optimum strategy is conservative measures, and medication are limited to those that really need medications with their delirium. These are my references that I've used. Thank you very much for listening to this talk. And if you have any questions, I'm more than happy to hear now. Thank you.